Julia. I'm really happy to be here today to talk about one of my favorite topics, which is relationship with our patients. What I'm going to do today is I'm going to review research on the provider-patient relationship. This research is really only in the beginning stages in the field of chronic pain in general. So I'm going to pull a lot from the field of psychotherapy, where we have a much longer history with looking at this issue. I'm going to try to just give an overview of the research to spend more time on the neuroscience aspect. So I'm going to review the neuroscience, and then I'm going to go on to the key strategies that we need to know for building a relationship with our patients and getting the benefit out of therapeutic relationship. I'm going to talk a little bit about what to do with conflict, and I'm going to talk about how we can use a relationship to support change. And in the end, I'm going to talk about the role of hope and how we look at self-care.
Okay, Julie, you can go ahead and share your screen. Wonderful.
Okay. We asked if anybody wanted to send in some challenging patient interactions that we can speak to. So I've got some, and if you want to add any, please just use the chat function and send them in as I'm speaking, and at the end we can try to get to some of those. Now I'm having difficulty moving on my presentation. There we go. Okay, so challenging relationships. Clinician-patient relationships in chronic pain management are considered to be among the most challenging in healthcare. Chronic pain management can be time-consuming, frustrating, and distressing for clinicians and patients. This is from Bushman last year. Now, we all know this working in chronic pain. We must often navigate strong emotions in our relationships with pain patients. Our patients are often frustrated, they're angry, they're sad, they're anxious. Their situations are often complex, with complex medical issues, possibly mental health issues, social factors. Now, most of us went into healthcare for reasons of wanting to help people. We also feel frustrated in these interactions with pain patients often. We want to help, but there are often no easy answers. We often feel like we're not doing a great job. They're not the feel-good type of patient interactions. And we end up sometimes dreading some of these patients coming in, and we end up sometimes feeling like we maybe can't help them the way we want to, or maybe that they don't want to be helped. The literature actually says that many pain patients end up reporting that they have suboptimal relationships with their providers. There's a study by Gulbranson in 2010, and what they found was that the communication problems between patient and physician seemed to even increase with the longer the duration of the illness, which is concerning. And one study also found that 15% of general practitioners' interactions each day are considered challenging. So I wonder how you all feel about that, if you would think that the 15% of interactions in a day are challenging in your practice as well. Now, the thing is that having a good relationship with our patients has long been an assumption of practice, but we don't always know what to do with the challenging situations that occur. And sometimes we feel like we're too busy to address them. That's a big problem in healthcare, is that patients are coming quickly and we don't have a lot of time. But truly, the difficulty with a challenging patient, I put challenging patient in quotes, is in the relationship. So what I want to do today is really reframe how we look at our relationships with patients, and particularly with the neuroscience info. So if we look at the research on relationship in healthcare, the association between a good patient and doctor relationship, I'm looking at the doctor research now, the association between a good relationship and patient satisfaction and adherence to treatment is well documented. We've looked at that for a long time. The better the relationship, the more our patients will adhere to the treatment plans that we've agreed upon. Okay, that's fairly common knowledge. Griffin looked at 25 studies where they did interventions to try to improve the relationship between patients and their doctors, and they found statistically significant effects on health outcomes. Okay, that's really quite a large number. They found 44% had better health outcomes when the relationship with their provider improved. And researchers argue that for those with chronic pain, the patient-physician relationship is particularly relevant because there's a lot of issues in the differences of opinion about the models of illness and treatment between the doctor and the patient. Treatment expectations and goals can often differ. A couple of other researchers really looked a lot at the psychotherapy literature and identified the aspects relevant to chronic pain. Because as I said before, in psychotherapy, we have looked at this a lot, and it has not so much been the case for chronic pain. So they actually concluded that the quality of the patient-provider relationship has a stable and predictable influence on outcomes. And the consistency was remarkable. Actually, over all the studies, they looked at 3 different meta-analyses, and they found that over the wide range of studies, they had different treatment approaches, different populations, different measures, but the effect of the relationship was stable across all these studies, showing a modest effect, really. But across all the studies, they found that the patient-provider relationship has a stable and predictable influence on outcomes. And the evidence really suggests that a positive response to treatment depends at least as much on the relationship between the patient and provider as it does on the technical aspects of the intervention. So they come to conclude that relationship is one of the hallmark ingredients of effective intervention in chronic pain. Now, this is somewhat different from what we spend a lot of time learning in school, what a lot of the literature is about. Really, a lot of it has us looking at techniques and different treatments. But what they're saying now is that relationship is one of the hallmark. It's a critical aspect of treatment with chronic pain patients. So it really needs to have more of our focus. So the provider characteristics that are related to a higher quality relationship, the literature shows that what patients would say is perceiving their providers as genuine, non-judgmental, attentive, respectful, and empathetic. Okay, this is what patients say leads to having a higher quality relationship with their healthcare providers. So I think that the research, when it starts to look more at the direct impact on health that relationship can have, I think this is where it starts to get more interesting, actually. So there's a lot of argument now in the literature that we have gone too far into the technical aspects of care, looking at techniques and technical expertise in chronic pain, and really have ended up paying too little attention to relationship. And relationship factors have actually been quite difficult to study over the years. But recently, they've had more focus, and we have some different ways to study them, which is quite interesting. I'll talk a little bit about that later, functional MRIs and PET scans and things like that. So research is now looking more directly at how relationships can impact patient outcomes. So one study that is interesting, it's not directly related to chronic pain, but it is an interesting study, so I'm going to talk about it anyways. Reichel and his group in 2009 looked at the role of empathy in medical consultations to outcomes with a common cold. So they did a randomized control trial, and they looked at patient-practitioner interaction. So basically what they did was they had the doctor administer what they called a dose of empathy. Okay, so this was in a 1 session in an office. And some of the patients got an empathetic response to the fact that they had a cold, and some did not. And they assessed patients' experience of empathy in their consultation. So they looked at subjective factors, what the patient said about it, their symptom reports, and then they gave them a nasal wash to measure immune markers. Okay. So what they found, those with higher perceived empathy from their doctors had a shorter duration and severity of the cold. And they actually were able to prove this with immune markers. So people actually got better a full day earlier if they had empathy. So they were able to finally look at the fact that empathy can directly impact our immune system, which was fascinating. And it was really a new thing that they were able to do this. So I'm going to get to the direct impact on pain in just a moment. For years in the therapy literature, we've been looking at therapeutic relationship. And this is where I think psychotherapy can really contribute to healthcare in general. And there has been an argument, and there's a very popular argument, that there's actually little difference in outcomes across the various forms of psychotherapy. So people talk about doing CBT or different things, DBT, there's all kinds of techniques that are used in psychotherapy, and what they're finding now that relationship is actually the most significant factor in an outcome. Doesn't matter what model you actually use. So we have a poll now. Leah, I'll hand that to you, I think, to put up the poll question.
Okay, here we go.
Okay, so which factors facilitate the possibility of having a placebo effect in treatment? And is it the patient's conscious expectations, classical conditioning, the clinician's facial expressions and verbal expressions of support, A and B, or we're actually supposed to have all of the above on there too?
Okay, I think most people have voted. I'll give it a few more seconds, and I'll close the poll in about 5 more seconds. Oh, we've got some people changing their mind. That's great. Okay. This is your last chance to vote. Okay, I'm going to close the poll now. Thank you very much. And here are our results.
All right, great. So the answer actually is all of the above. So placebo actually in Latin means I shall please. And a placebo effect is created by contextual factors that influence the patient and have a positive psychological and neurobiological effect. So these are the effects that are beyond those that are expected by the intervention done or the technique used. We often think of this as the sugar pill generating a positive outcome for a patient. Okay? And nocebo is the opposite. In Latin, it means I shall harm. And it's the contextual factors that have negative psychological and neurobiological effects. So from the physio literature, there's now a lot of discussion in the past 3 or 4 years on the management of placebo effects and the avoidance of nocebo responses in patient interactions. And they've been suggested as really promising additions to clinical practice.
And Julie, do you want to just move to the next slide, or do you want me to share those poll results again?
Sure, let's move to the next slide.
Okay, go ahead.
Let's see if I can do that.
So I just had a quick question because some people weren't sure. It looks like they were voting maybe A and B. Did you have any comments you wanted to share about that? I remember you saying that in the past the answer may have been A and B.
Oh, there we go.
Now it's different.
Yes, I'm just going to go on to that if I can find my way back here.
Yeah, there you go.
There we go. Okay.
Wonderful.
Okay. So yeah, the answer is all of the above. And the thing is we have long known about the role of expectation and classical conditioning, reward learning, observational and social learning, and placebo. So those would be the A and B. We've also long known that patient characteristics affect whether we get a placebo effect, things like personality traits or how somatically focused people are. But since about 2013, people have been looking more at other factors influencing placebo. And what they have found is that placebo can be influenced by the practitioner-patient relationship and characteristics of the provider. So I think this is interesting. The factors that they've actually found influence whether you get a placebo effect or not are things like the perceived competence and professionalism of the provider, okay, how professional we appear as clinicians, whether the clinicians are optimistic or pessimistic, how we give information, how empathetic we are, what our nonverbal communication is like, facial expressions, are we listening to patients actively, do we give them verbal expressions of support, and how do we encourage questions from them? So there are actually a lot more things than we previously thought. Also, they've been looking at aspects of the healthcare setting influencing placebo. So patients' perceptions of care are also relevant, or also dependent on, do they feel like this is a setting that is comforting to them or appears competent? So these things all influence patient expectations, which goes back to what we previously knew about placebo, but they also seem to have more of a direct impact on outcomes, on people's pain levels and things like that. And I think that in a minute, neuroscience can start to explain part of that. So what the literature is now arguing is that placebo and nocebo elements are always present during therapeutic interactions. They interact with a specific effect of the therapy, the technique we use to increase or decrease the global effect of treatment. So I think this actually really adds a lot of responsibility to us as care providers to think about that anytime we're interacting with a patient, we can get a placebo effect. We can get an added effect on top of the technique we're using. Or we can get the opposite. We can have the technique, the effectiveness of the technique decreased by our relationship. So we really want to be aware of maximizing the potential impact of placebo in chronic pain and using relationship to do that. And I like this little cartoon which says, do you have the placebo I've heard so much about? And I want to say yes. As a healthcare provider, we can add placebo in at any given point. So bear with me on the neuroscience part, because neuroscience is very complicated. I'm going to really try to simplify it here to the points I think are relevant. And I need to sort of start ahead of where we are with our patients. So bear with me, and hopefully this will all come together in a little bit. And then after this, we're probably going to get into a little bit of a more fun aspect, the how-to aspect with relationship. Okay. So I want to look at how relationship can influence emotions and emotional regulation, because we know that managing the challenging emotions that are often associated with chronic pain are difficult for many of our patients. And emotion plays such a significant role in people's pain experience. So Alan Shore is a psychologist and a neuroscientist, and he's written on some of the most exciting information I've seen about the impact of therapeutic relationship on the patient. If you are interested in more detailed science, I've put some references at the end, and he also has a great website. He's a very prolific writer, so you can go to his website and find many articles. So, and honestly, I saw Alan Shore speak in the States more than 10 years ago, and when I first learned the information that he had on therapeutic relationship, it was amazing to me. It completely changed how I looked at my practice. It was a complete mind shift in a day's session. So let me see if I can give you that little bit of information now. Okay, so self-regulation of emotion is a concept that's talked about a lot. When we talk about it, we're talking about generally the set of control processes by which we influence consciously and voluntarily our emotions and how we experience and express them. So schools talk a lot about self-regulation these days, teaching kids how to regulate their emotional states. We teach our pain patients this information. For example, we talk about things like, if I feel stressed, if I notice I'm feeling stressed, I can take some deep breaths. And that's our idea of what it means to self-regulate our emotions. And that's important because there definitely is a voluntary and conscious part to self-regulation. But what neuroscience has found is truly the majority of self-regulation happens at a non-conscious level, systems that are non-conscious to us. So the right hemisphere of our brain is actually dominant. Just a little bit of background on the right hemisphere, and this is simplified, I will say again. The right hemisphere of our brain is dominant for the recognition of emotions, the expression of spontaneous and intense emotions, and the nonverbal communication of emotions. And the right hemisphere of our brain has the strongest links into our limbic system, which is thought to be the system that does the most work in regulating our emotions. Okay. We learn to regulate our emotions and grow the pathways for regulating emotions through interaction with other humans. Right brain to right brain connections. I'm going to talk about what that looks like in a minute. Okay. So going way back, scientists and clinicians agree that the unconscious part of regulating our emotions evolves early in life in our attachment experiences. So the interaction between a baby and the caregiver. So you know how it is when we respond to babies, right? We all are biologically set to have a response to babies. So when babies coo, we make faces at them and we coo back. When babies cry, we feel it and we want to do something to soothe them. That's why when you hear a baby crying, it's really hard to ignore it. Even if it's not yours, it's really hard because biologically we're set to want to soothe that. If a baby's happy, we often want to join them in that, right? This is where you get the back and forth playing and making faces at each other. And if they're overexcited, we respond to them and help them calm. And what happens between a baby and their caregiver is often they get into a state of synchrony, where the caregiver is tracking the baby's emotions and having a similar emotion in response, and then helping them to regulate it when it kind of gets into the higher low levels. So when they get too high into excitement, we help bring them down. And when they get too upset, we help bring them back. So what actually happens is a dual process of regulation. It's called interactive regulation. So babies are helped to regulate, And through this, they build the neural pathways to regulate themselves. So it's interesting, Alan Shore actually shows PET scans and functional MRI pictures and shows that when a parent is interacting with their very young baby, that similar brain areas are activated in the parent and the baby. And what's actually happening is the baby is growing pathways through the limbic system, through that connection to regulate their own emotions. So through the relationship, our tolerance to manage emotional states increases. We get actual pathways in our brain to manage emotional states. And then the human nervous system myelinates during the first year and a half. And so what that really means is that we have our abilities to regulate emotions set down very early in life. And this is where the right brain to right brain comes in. So that connection between the caregiver and the baby, where they're in a synchrony, is right brain to right brain. Okay, we're going to use that again later. And again, simplified. So these attachment experiences that allow us to learn how to regulate emotions also impact other areas. And what they found is that the regulation of the limbic system can also impact other systems like the endocrine system, central nervous system, immune system, cardiovascular system. How this relates to chronic pain. Many of our patients are struggling to self-regulate the emotions associated with pain. Their experiences are really often too overwhelming for their capacity. The pain levels they have are too distressing for what they have to manage it. Also, we have to remember that many of our pain patients have adverse childhood experiences, and so they may have not developed sufficient pathways or enough to then regulate what comes later as a really distressing experience of pain. And many have also had a lot of trauma, which impacts their ability to regulate. So I hope that part was clear. I'm now going to apply this to what we can do with our patients now. Okay. This is the really amazing part. This is what really shifted me, is that research has now shown that we can access and continue to build these self-regulation pathways throughout life. Okay. So really what's happened now is all forms of psychotherapy share a common goal of improving the effectiveness of patients' emotional self-regulation. So only a part of that is what we teach them, the ways we teach them to do things like deep breathing in order to regulate when they're stressed. The other part of it is this relationship to relationship, right brain to right brain connection that can actually build neural pathways for them to auto-regulate their emotions later on. So we can do with them what a caregiver would do with a baby, again, in life. So this is why studies show that the method of therapy is much less important than the quality of the relationship. So psychotherapy is using the same process as early attachment. So I guess what I want us all to remember in working with patients is not only can we have a good relationship with a patient that then, has them want to adhere to the treatment plan we've set up, but we can also start to reshape their brain to directly impact those neural pathways that they have. And on a shorter term, I actually guess, sorry, before I say that, I should say we also have to assume that all relationship has the potential to create these deeper level changes. It doesn't actually have to mean the therapy hour, because sometimes people come back to me on this and say, well, I don't have an hour with my patient like a psychotherapist would have. But actually, brief interactions with healthcare professionals, if they are attuned and synchronous, like with the baby caregiver, can have the same kind of brain growth. It doesn't have to be an hour. And I think we see our patients, depending on what professions you're coming from or what your clinical setup is, sometimes we see these patients week after week after week, or we spend a lot of time with them at various periods. So we actually have the ability to reshape their ability to self-regulate through these interactions. And on a shorter term basis, there's another piece to this too from the neuroscience that I think is kind of interesting, is the therapeutic relationship can also act as the antithesis of the fight or flight response. So I think we talk quite a lot in chronic pain about the fact that our patients are in a chronic fight or flight response. Well, what we know now is the experience of feeling cared about in a relationship reduces the secretion of stress hormones and can shift the neuroendocrine system towards homeostasis. So the social bonds actually can reduce the stress-induced arousal. So for example, if a child has a stressful experience, they get scared by something, they'll often go and run to their parent. And the parent will, care and soothe them, and that will actually reduce the stress response. And we're biologically set up for that. Animals reduce their stress response by being in their social group. So if something that creates a fight or flight response in an animal happens and they then run back to their pack, that turns off the response. The social bonds are actually the opposite of the fight or flight stress response. And if you want to read more about that, Stephen Porges looks at that, and I put a reference in there. So even in our very short-term relationships, we can help to turn off that fight or flight response in our patients. So I hope that was clear. Leah, do you have any questions about that?
No, that was very clear, and I don't see any questions at this point in the chat, but feel free, everybody, to enter them in as they pop up. Okay. I think we're good to proceed. Julie, thanks.
Okay. I know the neuroscience is a bit confusing, but I think it's really amazing because it really validates what we can do. It really, if we think that we can create this kind of concrete change in a patient, it's very, very powerful. So what I want to talk about is what we want in patient interactions. So truly what we want is for practitioners to be present, or I like to call it to show up emotionally. Okay? So that means to be in the moment with the patient and try to be open to their experience, to try to actually feel their emotional state. We want a right brain to right brain connection, like the connection between the infant and the caregiver. What we don't want is to have what I would call emotional arm's length care. So we can actually provide care to our patients without emotionally showing up. For example, I had a family member who went to his first colonoscopy. He was anxious, very anxious, as you can imagine, going to a colonoscopy. Went into the waiting room and met the nurse and was given a gown and sat there and was given all kinds of directions and came back and said nobody noticed how anxious he was. Nobody responded to his anxiety. It was all very factual. Here's what you need to do. And I think that is a great example of emotional arm's length care. Right? They did the technical aspects, or they did what they needed to do, but they never noticed his emotion. And I was also asked when I talked about this one time by a home health OT about how you can connect more. And I think when I was thinking about it, in home health, so say you're going to see your elderly patient and your job is to check that the walker is the right size and fitting right, and do some modifications to the home. You can easily go in there and do those things without actually responding to the emotion of the patient. And you may have, and in this case, the situation I was given was an elderly woman who was really lonely and really worried about being on her own and actually really wanted the OT to sit down and spend a bunch of time having tea and talking. And the OT said, I don't have the amount of time to sit there and drink tea and hear the story. And to that, I would say, I think we can actually respond to the emotion briefly and not ignore it, and then still get the work done, the other part of the work, which is, assessing for devices they might need, shower bars and that kind of thing. Okay. I've even seen arm's length care given in psychotherapy. We can provide mental health care counseling that way, such as giving, modules of teaching CBT skills without actually connecting with the patient's feelings. So what we really want to do is work towards being more present and showing up emotionally with our patients. And I wanted to show a little video, and I'm not sure if my technology is going to work, but this was a video done by Fraser Health. It's called Moments to Milestones. You can see the whole thing on YouTube. And it was a training video for first responders on dealing with people with addictions. And this little clip, if I can get it, is a colleague of mine. His name's Don, and he works at Surrey Memorial, and he's a psychiatric nurse. And I'm going to see if I can play this for you. Okay, he's the next one, I think, so just bear with me on this.
To help remind people of who they are and help remind people of what matters.
I was pulling a big shift. I used to remember.
So you might have to turn up the volume just a little bit, and we'll just start it again from the beginning.
Some of the put him in the interview room too, and
Yeah, and just while we're waiting to play it again, if the quality isn't great for our viewers, we can always share the link afterwards, and you can watch it again at home.
Everybody is somebody's son or daughter.
Sorry.
I came in and I introduced myself, and I said, you know, what can I do to help you for today? He was down and out. All his sponsors kind of just, he felt that the doors were closing in on him. And we just kept on talking, and, you know, we got more into personal history of just being real. I think about 18 months later, he came back and presented to the ER. That was a busy day. I still remember it very clearly. I went out, and yeah, just as I came around the corner, I recognized him. You know, he just came to tell me that he was 18 months clean. So, yeah.
Today, I live in a beautiful home.
Okay, now I'm going to try to get back here to my slides. Sorry. Oops, and now we're not in the right place. I'm going to zip through them, I think. Somehow that didn't work properly.
That's okay.
Okay.
You could just give a quick summary of the video. I'm not sure if people caught the beginning, but just what were the key points you wanted us to pay attention to?
So I think what happened here is Don met with a patient in emergency, and it was a busy day, and that's often the time when it's harder for us to truly connect. And what happened here was Don was really real with this patient, right? He was curious about him, he listened to his story, and they had a conversation about what was really going on for this patient. And it wasn't long, and 18 months later this patient came back, and it had had a huge impact on him. And I think it's interesting to watch Don in this video too, because that interaction really impacted him as well. So I think this is a great example of being real. Right? Don's not talking about doing anything technical. He didn't use any specific techniques. He was actually there and real and present with this patient, and it had a huge impact on him. And on the flip side of that, I mean, it would have been easy to actually hand this patient a few resources and talk about what he could do with his, with his addictions issues, and here's a center you could call, and probably would not have had the same impact on the patient. And that would have been more emotional, arm's length kind of care. Okay, so this is the how-to part, okay? What we need, the two key aspects of relationship are attunement. So that attunement is staying present with the emotional state of our patient, and which I'm going to talk a lot more about, and validation. And that's the what we say part, the trying to hear and understand and acknowledge a patient's feeling, and looking for the feelings behind the content. And I'm going to come more to that too. But the research has actually shown with, and again, it's on doctors. A lot of this research has been with doctors. But the research actually shows that many doctors tend to overestimate their ability in communication. And I think that we all do this actually. And the most important part to this is actually attunement. Communication skills are taught a lot, and attunement is usually left out. So that's part of what I want to focus on here. And I think even with this validation part, a lot of people who are trying to do it don't quite get it. We often kind of miss the mark with this because it is challenging. So I'm going to come to that more later on too. It's quite a misunderstood process, I think. So the other thing that's kind of exciting in this is that there is research to show that we can be taught this. It's the communication skills plus the attunement. And we can use it more successfully in practice. And the research is showing that even when the time for direct patient contact is limited, we can use these skills well. So first, attunement. From a neuroscience perspective, when we use attunement, we actually help patients expand their ability to tolerate both negative and positive affect. Okay, we actually have to remember that we usually think of negative emotion as being the toughest to manage. Positive emotion, the really high ends of it, like joy and super excitement, are also hard to manage. But When we attune, we help patients expand their ability to tolerate both ends of emotion. So what we want to do with patients is we want to track their emotional state. We want to pay attention to it, just like we would with a baby. And we want to respond to not only just what they're saying, because patients will tell us a lot of things, but we want to see what we want to look for what they're showing us in other ways. We want to respond to what we see and what we feel in that interaction, and really track and follow it. Okay. So studies show that 60% of human communication is nonverbal. So we read people's behavior, their postures, their gestures so much faster than we can process language. So when we attune to them, they're also reading our expressions and our body language much faster than what we're saying as well. So that's why attunement becomes so important. They get that first. So attunement involves our facial expressions, prosody, which is how we match tones in our voices. So if someone's coming at us really quietly, we don't talk back to them in a really loud voice. We try to sort of match, and our gestures. So what we want to do is try to be really curious about the patient's experience. Just spend some moments sitting there and being curious about what's happening for them and trying to match it a little bit, okay? And I think sometimes when we do this, we are too cognitive about it. Well, we want to try to take that piece out, because when we're with patients, we're often thinking about what we're going to say next. We want to kind of leave that out. And even when we say try to put ourselves in their shoes, often that's a little bit too cognitive too, because we don't want to try to imagine what it's like to be them. We want to actually sit there and kind of feel what we're getting from them and just experience what's happening. So we want to join them in their emotional space and be with them, especially when they're struggling. So for example, if a patient comes in crying, their situation hasn't improved. We've probably all had this a lot. We want to put down what we're doing and just sit there and see what it feels like for them. And we have to feel that ourselves for a moment. We have to touch their feelings. So we have to also experience the same feeling. Now, this is where people often tell me they don't want to do this. And I get it, because patients come in often very distressing states. And this means that we have to jump into feeling what they're feeling. So it's hard, and we're sometimes afraid of getting into these really big emotions. But we really need to do this just briefly, and then our bodies naturally shift into this interactive regulation, and we will move out of it. Okay, so we have to feel it just briefly and know that together we're going to move out of it. The only thing to really be careful with is serious despair, because if we spend too much time feeling someone else's serious despair, we will both wallow in it. With despair, we kind of have to then shift the topic a little bit after we felt it. But most other things, together, we will regulate ourselves out of it. Now, validation is the what we say, and probably many of you have had some training in validation or what to say communication skills. But really what validation is we want to show that we're trying to understand what a person is feeling. So what we want to do is look for the emotion behind what they're saying and doing and try to guess at a label for it. Okay? It's only a guess. We don't have to be right. The value is in trying to understand. So have you ever had that experience of someone getting it for you? Like when you told them about all the upsetting things that your boss said today? You don't want your friend to then justify your boss's behavior or talk about how to fix a situation. What you really want is for them to just get it, to get that it was a tough day for you. And that's what our patients want too. So for example, patient comes in and they give us a long list of things they weren't able to do this weekend because of their pain. What they want is for you to guess. Seems like you're feeling frustrated about your weekend. Maybe you're worried about your functioning. Like just pick an emotion that might be there and throw it out as a guess. The value is in being curious. Okay. What I like about this is we don't actually have to have answers for our patients in some ways, because we don't want to be solving the problem or giving advice. The first thing we want to do with a patient is just get it. And it doesn't mean that you agree. We have to be careful with that too. Just because you validate a patient doesn't mean you agree with them. So they might tell you how terrible their previous physiotherapist was. By noting that they're frustrated or disappointed doesn't mean that you're agreeing that that physio was terrible. okay? It's just that you're getting their feeling. So the other thing is we have to check in with our own emotional state, because if something, you know, if we're feeling stressed or anxious, it becomes a lot harder to validate patients. So here's a little kind of a formula, although I don't want this to be too formula, because that's when it sounds too scripted, we take out the attunement part. But here's a few things you can try with a patient, okay? You seem to be disappointed. You look angry, or you look frustrated. And if you don't know what feeling's happening, you can always say, it seems like things feel very difficult for you. So the other aspect in this is that we want to maintain curiosity, okay? It feels really annoying if someone says to you, you're angry. Our response is often, no, I'm not. So you really want to say this in a way that is guessing at their feeling. So these are the two things, the two core skills, the attunement, which is not often taught to us, and the validation that we really need to build these relationships that are going to help our patients learn to regulate themselves better and build the pathways for regulation. Now, people often ask me, what about conflict? Because conflict is when things get really hard. So conflict is part of relationship. It's going to happen. And it actually is an opportunity. And I think we need to look at it that way. So when we have conflict, and people will come into our practices and they will disagree with us on many things. They will want things from us that we can't provide, for example, medications that we can't provide or we don't think are a good idea. But when we can get through conflict, we can often have a better relationship with that patient. Our chronic pain patients are often our longer term patients. So if we can get to a point where they can express their conflict outright with us instead of, you know, not saying what they're really thinking, and we can get to a point where we can have differences of opinion, we often have a better relationship. The other thing that we know is that with neuroplasticity, the theory is that more brain systems are actually active during high emotional states. So the intensity of arousal is greater. So with that, the opportunity for learning and for growing new neural pathways is actually greater when people are in higher emotional states. So Alan Shore talks about this. So we really need to use these conflict situations and see them as opportunities for change. So what we want to do in conflict, you can see in this picture, that's pretty conflictual, is we want to attune and validate. The same skills, we want to use them in conflict. And oftentimes we have to attune and validate before we can move on. So there is a study done with doctors that says it takes between 2 and 5 minutes to shift a patient out of a very high angry state. And if we don't do that, we can actually spend our entire session getting nowhere. But if we spend 2 to 5 minutes attuning to them and validating the emotion they're having, we can get through it and then move on to other things. The big goal is to be emotionally present, which is sometimes hard because we often get triggered by angry patients. We want to try our best to be present and to be curious about their experience. We don't want to get stuck in, you know, defending ourselves and talking about the details. We really want to feel their anger briefly and comment on it. It seems like you're really angry. And then look for what else is there, because anger is usually just at the top, and below it are usually things like sadness and frustration and fear. So we may want to go on to say, it seems like you're really worried about what's happening, or it seems like you're really sad about this, and respond to what's happening there. Remember that validation doesn't mean that you agree with them either, okay? It just means that you're trying to get it, and they will notice that you're trying to get it. And the other thing I should say about conflict is that we also need to put boundaries on it, because it's not okay to accept destructive behavior. So they can feel angry, but they can't call you names. So there are many times where I've said that to patients, like, I see that you're really angry, and, you know, I'd be interested to hear more about that anger. I can't hear you when you're swearing at me. So, you know, if we can change that and we can talk about it, that's fine. But if you're going to swear at me, it makes it really hard for me to hear you. Okay. Actually, maybe before I do that, I'll just give another little example with an angry patient, which probably some people have had. Patients can sometimes be angry that they're not going to get referred for something like a surgery consult. So what we want to do with that too is attune to the anger. You seem really angry. Feel it. Sit with it. We can't move on too quickly. And comment how it seems like you're really hoping for a surgery solution. Sit with it. And they will come down from it within 2 to 5 minutes. Sometimes you just have to, maintain the hope in this theory, but it really shows time and time again that people do come down if they're responded to in this way, and you'll be able to move on. Okay, so a little bit about change. Relationships we have with our patients can support change. They can also have a negative impact on change. We really need to take a look at the messages that we give about change. One of the things that happens is the whole topic of change sometimes has an unintended message. When we tell someone to change, it sometimes means to them that we're saying that they're not good enough already. So dialectical behavior therapy really looks at this. And we have to be careful because many of our patients come to us after a long history with the healthcare system, and many things have failed in their opinion, things they've tried. We want to be careful that they don't have this perspective on themselves, that we're not reinforcing a perspective on themselves that they're not good enough. We want to accept where they're at and encourage change. So the one way I use neuroscience in this is I sometimes talk about the fact that what we want them to do is actually grow and build on what they already have. So I sometimes change the language from change to growth. So I sometimes say things like, it makes a lot of sense why you're struggling, and they're big struggles, and you've really done the best you can. And now we might want to add a few strategies to what you already have. That might be helpful. The other thing that we need to do with change, which I think doesn't happen often enough, is validate how hard it is for patients. There's a lot of anxiety with change, right? We're heading into something new. Sometimes there's losses when we change our behavior, and it's not acknowledged a lot. So we want to validate with patients, especially if they're not taking steps to change things too quickly. We may want to notice, like, it's really hard to change. How does it feel? It can bring up a lot of anxiety when we do new things. And sometimes for really stuck patients, that's what's happened. The anxiety about changing is actually outweighing the benefit for them. So can we do another little quick poll, Leah?
Absolutely.
Okay.
We have a few minutes left, so we'll probably do this one pretty quickly. Here you go. Give you a few seconds to vote.
How often do you make concrete, detailed goals with patients and then follow up in the next session? I think this is something that seems really obvious to patients. Like, we don't often go through the steps to follow up and to even make the detailed goals. I've been complacent with this many times and been burned by it, honestly. We say, you need to increase your exercise. That would be really helpful. And without sitting down and actually talking about when and where and who you're going to do it with and how, patients really struggle to do that on their own. Great. People are doing this often.
Looks like 67% often. Okay.
Great, good for you. There's some great ways to do that. The Live Plan B website has a great goal tracker. And we can use SMART goals with our patients, things like that. I try to get out of the, there we go. Okay, that worked better this time. Quickly, I want to just talk about a little bit how we view change and success. With patients with chronic pain, we have to expect it to be slow. And, good changes are often slow. So I think how we frame it has an impact for the patient and also our ability to withstand in this field. So we need to look at things like, did they meet part of their goal, or, did they change a couple of points on a pain reduction scale? We have to look at that kind of stuff. But another thing that I really want to talk about is we need to point out our patients' strengths and highlight what they've done well. So even if they've only done a small piece of the goals we set out for them, really focusing on that. And dialectical behavior therapy has this concept of being a cheerleader for our patients. And although that may sound a little bit hokey, actually, many of our patients feel quite hopeless and quite passive about things and really can't cheerlead themselves. And from session to session, it often kind of falls apart on them. So it becomes really important for us to value and acknowledge their efforts that they can't do for themselves. So I often see my job as being a cheerleader for patients. And over time, they often become better at cheerleading themselves. So don't underestimate too, even the patients that look like they're doing a good job of this sometimes aren't doing such a good job. So really keep this as a goal in cheerleading them. And goal setting is really an opportunity for being a cheerleader, because we can look at, the incremental changes that have happened. And the other thing I want to comment is on that we really want to celebrate progress. We have to really notice the progress our patients are making, because they may be hyper aware if we don't notice. I know we're not having a lot of time yet, but I wanted to give you this analogy that I often do. I usually tell patients that they've already changed, that they've learned and tried something new, and it can't be unlearned. So even if they say that they're not doing things well or not doing it very often, I say, the fact that you have tried this deep breathing exercise, you've learned it. Something has already changed. And then I give them the story of the snowfield. I tell them that learning a new skill is like creating a pathway in a snowfield, a very deep snowfield. We tend to travel down the worn path. So if we look at this field of snow, we will go down that pathway instead of going through the deep, deep snow around it. It's the easiest thing to do. If we want to try something new for the first time, it's like forging a new path in the snow. It's slow going and it's difficult. We're trudging through that deep snow. That's why learning a new skill feels difficult. But each time we go down that path, the path gets more compacted and easier to travel. And I like to visualize creating new brain pathways as the same thing. Our first attempts at learning a new skill, say an exercise, are like trudging through that waist-deep snow. It feels hard, but it gets easier and easier. And we can visualize that each attempt is like putting a few new steps into that pathway in the snow that's then going to pat it down and make it easier and easier to use. A little comment on hope is that studies have found that interactions with healthcare professionals hold the power to diminish or enhance hope. Things like being there and showing care and concern. So again, that's attunement and validation can impact hope. And our patients often struggle with their level of distress and their histories and what's happening for them. They have really severe difficulties in maintaining hope. So we often have to be the ones to see the hope and to hold it for them and convey it on an ongoing basis. They often actually depend on us for that. A couple of comments on self-care. So what a lot of people say to me is, I don't want to attune to patients because I don't want to take on those difficult feelings that they have. And really having an empathic connection with our clients, it allows them to get better, but it does open us up to vicarious trauma and things like burnout and compassion and fatigue that we have to be really careful about. And I mean, that's a great topic, which is way beyond what I could do today, is to talk about that. But what I think we really need to remember is that in order to help our patients regulate and grow new self-regulatory processes in their brains, we need to attend to our self-care. We need to be regulated. And in healthcare, what I found is practitioners are usually pretty bad at this. We don't focus a lot. We focus a lot on helping other people and not ourselves. So we really need to think about it, and we need to think about what's truly self-care. Often a lot of lip service is given to this, but we need to look for the things that truly help us feel calmer and things that truly bring us joy, and adding them to our week and also having them as a plan. So on a really bad day, ahead of time, I have a plan that what I'll do if I've had a really tough day at work and I feel really emotionally drained, this is what I'm going to do right after work. And maybe it's have a run with a friend before I go home, whatever it is, but having a plan and truly attending to this, because if we're not regulated, we're not going to help our patients be regulated. And we also need to encourage our system that we work in to focus more on relationship and supporting us to have relationship with our patients, which may be, having supervision around how we're doing with our relationship skills. And it may also be giving us the time for our self-care and actually having a focus on that. So I have some questions, Leah. I don't know that we have much time left.
I think we can continue. If people need to leave, that's fine. We'll continue recording, and we can always share this with everybody after the fact. So let's keep going, and we've had 2 questions in the chat so far, so let me know when you want me to read those out.
Okay, should I just do a couple of my common questions and?
Yeah, I think that's a great way to proceed. Thanks.
Okay, so when I do a lot of talks on this topic, and people often say to me, how can I use attunement and validation when my sessions are brief? I say, I don't feel like I have time to do this. And what I say to that is that attunement and validation can be really brief. With our most highly emotional patients, like our most angry patients, for 2 to 5 minutes, if we spend on that, we can bring them down into a state that we can then have a different discussion. So a lot of GPs will say to me, I have 10 minutes with a patient. And I'll say, even if you get the highest level of emotion, you can deal with that in half your session. And then you have the other half to deal with whatever kind of practical issues you need to deal with. If you don't attend to the emotion, you may not get anywhere on other aspects of your session. So it can be brief. You only need a few moments. And in terms of actually